So oceanic stroke was one of the largest stroke secondary prevention studies that's ever been completed. Over 12,000 patients enrolled. It looked at patients who had had stroke or TIA with some demonstrated evidence of some type of atherosclerosis or some hardening of the arteries. And that particular study looked at a wide range of patients who present with stroke, uh, from mild to more moderate, even to kind of the early severe stage of stroke. And patients enrolled in the study were randomized to either to receive a factor XIa inhibitor, Asundexian, or a placebo medication. Uh, the results of the study support the benefit of factor XIa inhibitors in providing additional reduction in stroke above that provided by just standard therapies. Um, these the use of the factor XIa inhibitors were used in combination with standard antiplatelet therapy medications, which are commonly used for stroke secondary prevention. And the benefit of the medicine was seen with an absolute risk reduction of about 2.2%. Uh, and, that compares to about a number needed to treat to prevent at least one stroke of about 46 patients during the study. Importantly, this study supports the whole new class of medications, which are now available to reduce the risk of stroke. Now, anytime you're adding and layering blood thinning medicines together, um, or anti-clotting medications together, um, I think it's really important to recognize that we're always concerned that we're adding bleeding risk, but that was not the case with Asundexian in the OCEANIC study. Essentially, patients benefited by a reduction in their ischemic stroke risk without a concomitant increase in bleeding risk. And this is critically important uh, as this medication is something that provided that benefit without that bleeding risk that we could be concerned about. Well, I think one of the most important things that we should recognize is that the prevention of second stroke or secondary prevention in general of stroke is important because when patients have another stroke after an initial stroke, it is often more disabling and uh, it not only produces more physical disability, but it layers on the prior stroke. It doesn't allow people to recover in the same way. And this can be devastating for individuals. So, this type of prevention strategy where we can add a medication layered on the existing approach and produce that kind of meaningful benefit in terms of reduction of risk for every patient that's not disabled, that's someone else that's able to contribute, that's able to live a more fulfilled life because they're not living with the disability they would have had from that second stroke. That's an excellent question. So factor XIa inhibitors are not anticoagulants. They don't provide the same degree necessarily of blood thinning that an anticoagulant does, but they provide an important benefit, and we've seen in not only the studies of factor XIa inhibitors, but also the mechanism, the science of why they work. That these medicines really act against what we would call like the pathologic clot, the clot that forms that's bad. So, whereas good clotting, that's part of the healing process, it doesn't act against that type of clotting as much. So, the benefit of the factor XIa inhibitors is that they're relatively selective in that sense, acting against the bad clot without harming the good clotting that's part of healing. Whereas anticoagulants in general are acting against a variety of clotting, whether it's the good kind of clotting we need for healing or the bad kind of clotting that's part of a pathologic process of a clot that could form uh, and travel to the brain and cause a stroke. Well, some of the interesting things that were noted in the study is that patients of all different subgroups benefited in the study. Um, Essentially, the study looked at people who had non-cardioembolic stroke, so not the strokes that form in the heart spontaneously and then travel to the brain, but strokes that may form because of blood vessel problems or spontaneously form in the arteries. So a lot of the patient in the study had that kind of atherosclerosis or hardening of the artery. Um, and when we look at the subgroups, every subgroup essentially had some degree of benefit. And there were many patients even with small blood vessel strokes, a large percentage of patients with strokes due to blockages of small blood vessels, and they benefited just as much as patients with larger artery narrowings due to that kind of atherosclerosis or hardening of the arteries. In addition, when you look at the patients were enrolled during a 72-hour or 3-day period initially, whether you were enrolled very early or you were enrolled later, you still benefited. In fact, patients who were enrolled in day 2 and 3 may have benefited in the sub-analysis uh, even more necessarily than someone who was treated on day 1. But overall, I think it's really important to recognize that regardless of the subgroups, benefit was seen across a wide variety of demographics, a wide variety of disease severity. Patients with lower stroke severity benefited just as much as patients with more stroke severity. I think it's important that we recognize that, we've been treating or using the same medications in different combinations for decades. The mainstays of therapy, aspirin's been available for over 100 years, since I think it's been over the counter since 1915. And medications like clopidogrel have been available since 1997. And these medicines used in combination are often the mainstay of early therapy, and then longer term use of a single mild blood thinning medication has been the standard of care. So I don't think that we're going to get away from the use of these medicines that become part of the standard care. And one of the things about this study, the oceanic studies, it showed that factor 11A inhibitors like asundexian can be layered on top of standard antiplatelet therapy and still provide meaningful reduction in stroke risk without a significant or concomitant increase in bleeding risk. And it's really important that you see that additional benefit, that absolute reduction in risk with the layering of factor 11A inhibitors without an increase in bleeding risk. There's two aspects that clinicians should take meaning away from the aspect of factor 11A inhibitors and how they work on reducing the pathologic clotting or the bad clotting while maintaining the good clotting. One, we know a lot about factor 11A, and during the active clotting process, um, when there is a pathologic clot, there is this accumulation of factor 11 that occurs in a different way than and a different activity than uh, in terms of factor 11 that is part of a healing process. The activity or the activated form of that factor 11 is what is being reduced as part of the pathologic clot. So that mechanism of action is important and well understood, not only about the factor 11A inhibitors in general, but specifically about asundexian. And that's reinforced in the oceanic study when you see that bleeding risk did not increase across the subgroup. So patients who are treated with asundexian and a combination of um, m- mild blood thinning medications did not see an increase in bleeding risk over being on a placebo plus those other mild blood thinners. So it's really important to recognize that not only does the mechanism make sense, but the activity or what we saw in the OCEANIC study supports that understanding of how Factor XIa works.